All right, let's dive into something you might not think about too often.
Okay.
Invasive fungal infections.
Yeah.
Before you go, ew, fungus, not my thing.
Right.
Trust me, it's fascinating stuff, especially for those in critical care. We're talking about some real medical mysteries here.
Absolutely.
And we're not just talking about athlete's foot.
No.
This is serious stuff getting into your bloodstream and organs.
Yeah.
We'll be focusing on two of the big players today, Candida and Aspergillus.
You know, what's interesting is these infections are a growing concern, especially for those who are critically ill.
Right.
And understanding them is crucial, not just for healthcare professionals,
Right.
but really for anyone who wants to stay ahead of the curve when it comes to emerging health threats.
Exactly. And the real challenge here is that these fungal infections are notoriously difficult to diagnose and treat.
Absolutely.
So let's jump right in. First up is invasive candidiasis.
Yeah.
Or IC for short. Think of it this way. It's a systemic infection caused by yeasts in the Candida family. Now, Candida albicans is usually the one we hear about.
Right, but it's actually getting interesting because we're seeing a rise in these non-albicans strains.
Okay.
And, you know, what's contributing to that?
What?
Our use of antifungals.
Oh.
It's like a medical arms race.
Really?
We use antifungals, and then they adapt to become resistant. Some of these new strains are much tougher to treat with the medications that we have.
So it's almost like they're outsmarting us.
In a way, yeah.
Wow. Okay, so this candida is causing trouble, but how does it actually show up in patients? How do we know?
Well, there are two main ways.
Okay.
One is candidemia, which is when the infection is in the bloodstream.
Mm-hmm.
And then there's deep-seated candidiasis, where the infection is in the organs or tissues.
Oh, so it's kind of hidden.
It can be very hard to pinpoint.
I bet blood tests are the go-to, right?
They are. But blood cultures, while useful for finding candida in the blood, can be slow and often miss those deeper infections. In fact, across all types of IC, blood cultures only have a sensitivity of about 50%.
So half the time they don't even work.
That's right.
Wow, doctors must feel like detectives trying to crack a case with missing clues.
Absolutely.
So what other tools do they have?
Well, there's the beta-D-glucan assay, or BDG for short.
Right.
This test detects parts of the fungal cell wall.
I see.
It's pretty sensitive, catching something like 74 to 86% of cases.
Okay.
But there's a catch.
Oh.
It can also flag false positives.
Oh, so it might show an infection even when there isn't one.
Exactly.
So not a perfect method.
Right.
Are there other markers that can help narrow things down?
Yeah, we also use the man antigen and anti-man antibodies.
Okay.
These tend to work better when used together.
So it's like a detective duo. Are
Exactly.
there any others?
There are some new molecular tests,
Okay.
but they still need more research before they're widely used.
So lots of options, but each with its own quirks.
Mm-hmm.
How do doctors even decide when to start treatment?
Well, that's the real dilemma.
Yeah.
Proven invasive candidiasis isn't super common,
Okay.
but UT delaying treatment can be fatal.
Wow, that's a tough situation.
It is. It's a high-stakes balancing act.
So how do doctors navigate that?
Well, they use a few different things.
Okay.
First, risk prediction models.
To figure out who's most likely to get it.
Exactly. And then they'll also factor in those non-culture diagnostics.
Like that BDG test we talked about.
Right. And of course, they carefully consider the patient's overall condition.
Right. And any other symptoms they're showing.
Exactly.
So no jumping the gun just because one test is positive.
You got it. Preemptive treatment just based on biomarkers isn't advisable.
Okay.
However, biomarkers can be really useful for helping doctors stop antifungal medications that aren't needed.
So minimizing side effects and resistance?
Exactly.
So let's say a doctor suspects IC.
Okay.
What's the go-to treatment?
For critically ill patients, it's usually echinocandins.
Echinocandins, those sound pretty serious.
They are effective.
How do they work?
Well, they target the fungal cell wall, preventing the fungus from growing and spreading.
That makes sense. But there are a bunch of different echinocandins, right?
That's right.
How many are there?
There are 4 main types: caspofungin, mycofungin, vanigulafungin, and risofungin.
Wow. Okay. And these echinocandins, they're fungicidal, right?
Yes, they are.
Wait, they actually kill the fungus.
They do.
That's amazing. So they don't just slow it down, they take it out.
Precisely.
Yeah.
That's why they're so effective for these serious infections.
So echinocandins are the heavy hitters. Are there any other antifungals used for candida?
Absolutely.
Like what?
Fluconazole,
Okay.
liposomal amphotericin B,
I see.
And source control is also really important.
Oh, right. Getting rid of anything that could be harboring the fungus.
Exactly, like infected catheters.
Makes sense, like cutting off the enemy's supply line.
Right.
But we can't forget about antifungal resistance.
Oh, absolutely. That's a growing problem.
Is it worse with certain species?
Yes, we're seeing it more and more, especially with C. glabrata, C. parapsilosis, and C. auris.
Those are becoming resistant.
They're some of the toughest ones to treat.
Oh, wow.
That's why it's so important to identify the specific species causing the infection
Yeah.
and to test its susceptibility to different antifungals.
So it's a constant back and forth.
It is.
Like a cat and mouse game.
Yeah,
Doctors also have to be on the lookout for those secondary foci of infection.
right.
Can you explain what that is?
So imagine the Candida infection starts somewhere, let's say the bloodstream,
Okay.
but then it spreads to other areas, like the heart, forming endocarditis, or even creates abscesses in different tissues.
Oh, wow.
These secondary foci can be really tricky to treat.
So these cases can get really complicated.
That's
So
right.
It's like a medical detective story.
It really is.
All right, so we've talked about Candida. Now let's turn our attention to Aspergillus.
Ready for round two.
Bring it on. So Aspergillus, it's not a yeast like Candida.
Right.
It's a filamentous fungus.
It grows in these long branching structures,
Exactly.
and it really seems to like the lungs.
Yeah, you're right.
About 90% of invasive aspergillosis cases involve the lungs.
It's usually either invasive pulmonary aspergillosis, IPA,
Okay.
or tracheobronchial aspergillosis, TBA.
So basically, aspergillus is going for the lungs.
Pretty much.
I always thought these serious fungal infections, they only really affected people with like really weak immune systems.
Right.
Like if you're on chemo or something,
Yeah.
transplant.
That was the traditional thinking.
Mm-hmm.
But we're seeing a change now.
Oh, really?
IPA is showing up in ICU patients who aren't as severely immunocompromised.
So it's kind of expanding its reach.
It is, and it's a concern.
It's like it's becoming more opportunistic,
Yeah,
taking advantage of any weakness.
exactly.
So who's at risk these days?
Well, the usual suspects are still there.
Like who?
People with solid tumors,
Okay.
uncontrolled HIV infection,
Mm-hmm.
or decompensated cirrhosis.
But it's also showing up in people with COPD.
Oh, wow.
People recovering from the flu, even those who's had COVID-19.
It's like any hit to your immune system.
Right.
Even if it's temporary, it leaves you open.
That's the idea.
What about corticosteroids? Those are a risk factor too, right?
Yeah. If you use them for a long time,
Okay.
it definitely increases your risk.
Mm-hmm.
But for short-term use in critical illness,
Right.
like for severe flu or COVID-19, it's less clear.
So there's still some debate.
Yeah, about the exact level of risk.
So doctors have to balance the benefits of these medications against the risk of a fungal infection.
It's a tough call.
Yeah, it is. So what are the signs a doctor should look for if they suspect IPA in an ICU patient?
Well, they really have to be vigilant.
Okay.
Any ICU patient with those risk factors.
Right.
If they have a fever that doesn't go away,
Mm-hmm.
chest pain, or worsening breathing,
Even if they're on antibiotics and a ventilator.
even then it should raise concerns.
So those symptoms in a patient with those risk factors, it's a big red flag.
Basically.
Okay, so suspicion is high.
Mm-hmm.
What's next? How do they confirm it?
Imaging is usually the first step.
Okay, like what?
CT scans of the chest,
To look for
specific patterns.
like what kind of patterns?
Things like infiltrates, hazy areas in the lungs,
Okay.
or halo signs and air crescent signs.
What are those?
They're more specific indicators of aspergillus.
I see.
If they think it's TBA,
Mm-hmm.
they might need a bronchoscopy.
And that's where to
Insert a thin tube with a camera,
into the lungs.
right, to get a closer look and take samples.
Okay, and then there are the mycological tests.
Right, to identify the fungus itself.
The fungal detectives.
Exactly.
So what do they look for in these tests?
Well, the galactomannan test is a key one.
Okay.
It detects an antigen produced by aspergillus.
So if it's a positive.
It depends
Sure.
where the sample came from.
How so?
If it's from a bronchoalveolar lavage,
Okay.
or BAL, a positive result is a pretty good indicator of IPA. But if it's from a blood test, it's less reliable, especially in patients who aren't neutropenic.
Meaning they have a normal white blood cell count.
Exactly.
So the patient's immune status matters.
It does.
What about other tests? Are there any backup singers?
Cultures are still useful,
Okay.
though they can take a while.
Yeah.
PCR tests can be helpful too.
Those detect the fungal DNA.
Right.
What else?
And there's a newer test The lateral flow assay,
The LFA.
yeah, it seems promising for speeding up treatment.
Well, that's always good news.
Absolutely.
Faster diagnosis, faster treatment.
Right.
But there's a balance, right,
There is always.
between starting treatment and getting a definitive diagnosis,
Sometimes they have to start treatment based on suspicion.
even before all the tests are back.
Sometimes, yeah.
Wow, that's a tough decision.
It is a life or death decision.
Okay, let's say IP is confirmed.
All right.
What's the treatment?
Well, here's where it gets interesting.
Okay.
Unlike with invasive candidiasis,
Where echinocandins are the first choice.
right, for IA, it's voriconazole.
Voriconazole.
It was shown to improve survival,
Compared to...
amphotericin B, which used to be the go-to.
So different fungus, different best weapon.
Yeah, that's the idea.
Are there other options?
Yes, there are other azole antifungals,
Like what? Oh,
plus iconazole,
okay.
isavuconazole.
I see.
But all of these azoles, they need to be monitored closely.
Why is that?
Their pharmacokinetics can be unpredictable.
Meaning how they're processed by the body?
Exactly, especially in critically ill patients.
Okay.
Plus, they can interact with other drugs.
So they're effective but tricky.
You could say that.
So what do they do?
Well, therapeutic drug monitoring is key.
Okay.
That's TDM for short.
And what is that?
It lets doctors measure the drug levels in the blood.
So they can adjust the dose.
Right, to make sure it's working and safe.
It's like personalized medicine.
Yeah, for fungal infections.
Very cool. But resistance is still a problem, right?
Oh, absolutely.
Even with all these tools.
It's always a concern.
Is it worse with certain species, like with Candida?
Yes, knowing the specific Aspergillus species and its resistance profile is really important,
Okay.
especially in areas where resistance is endemic.
So it's a constant battle.
It is. Always evolving.
But there are still some reliable backups, right?
Yes, liposomal amphotericin B is still valuable,
Okay.
especially if someone has liver failure or if TDM isn't available.
So it's good to have options.
Absolutely. We need a diverse arsenal.
So we've got the Candida crew and the Aspergillus army.
Two tough opponents.
What's the big picture here?
the takeaway?
So we've got the Candida crew and the Aspergillus army.
Two tough opponents.
What's the big picture here?
Well, the big picture is that invasive fungal infections are complex
Right.
and challenging.
Yeah.
But understanding them, the nuances of how to diagnose them
Mm.
and how to treat them, that's vital for helping patients.
It's, like we said, it's a medical mystery with incredibly high stakes.
It is.
Got to stay ahead of these fungi.
Absolutely.
Like a constant arms race.
It really is.
Which leads to a question for our listeners.
Okay.
As these infections become more common, even in people who aren't as immunocompromised,
Right.
what new strategies are we going to need
Yeah, what new tools for diagnosing and treating?
to meet this challenge?
How can we be more proactive
Yeah.
instead of reactive?
Yeah, that's a great question.
It is something to think about.
We've learned a lot about these infections
Right.
and how to manage them,
Yeah.
but there's always more to learn.
Absolutely.
The medical detectives are on the case.
Always.
It's a fascinating field,
It is.
constantly evolving,
Mm-hmm.
and it really shows how important research and innovation are in medicine.
Couldn't agree more.
So a huge thank you for joining us for this deep dive into invasive fungal infections.
Thanks for listening.
Hope you found it insightful,
Yeah.
maybe even a little thrilling.
In a medical mystery kind of way.
Right?
And maybe a little unsettling, too.
Yeah.
Knowing these things are out there.
But knowledge is power, right?
It is.
So keep exploring, keep learning.
Stay curious.
We'll catch you on our next deep dive.